Dr. Shafeena Premji is going to speak about menopause and hormone health. Yeah. We're ready for that. She is committed to reshaping how menopause is understood, treated, and experienced in Canada. All hail the Queen.
Oh, please. Please don't make me feel...
We need to hear you, so you just start talking.
It is such a pleasure and an honor to be here. Wow, I was not expecting such an amazing audience. This is incredible. It's such a pleasure to be here, and we have about 30 minutes together. I have a lot of information I want to share with all of you, so brace yourselves, and if I do go over, I'm more than happy to stay back to answer any questions you have about hormone therapy. So my talk is called Menopause and Hormone Health. Here are my disclosures. I'm a very fortunate member of the Canadian Menopause Society Board of Directors and on the Medical Advisory Board for the Menopause Foundation of Canada. I have not used any AI in the content creation of today's presentation. So I have to be honest, I'm very deathly afraid of public speaking. And therefore, I had to make a slide to remind myself why I'm here today. And the reason why I'm here today is because of those women in these photographs. These are my real patients. Judith, who is an average Canadian woman who's gone through menopause naturally. My patient, Shirley, who had a stroke and what's called a sudden coronary artery dissection. She is a miracle. I don't even know how she's still alive today. But when I see these women in these outfits looking empowered, it empowers me as a woman myself. So I'm here for these patients, and I'm here for each one of you, because when you thrive, and I get satisfaction and purpose in the work that I do. So thank you. So we're going to go through the W5s of menopausal hormone therapy. Now, when I started doing this work about 12, 13 years ago, nobody was talking about hormones, and all of my education was not through my traditional residency program or medical school. This required me to spend time attending medical conferences across the world, the Canadian Menopause Society, the Menopause Society in the US, and the International Menopause Society, which is why when all of you go to your family doctors and not getting answers, it's not because they are failing you, it's because our medical school curriculum has unfortunately not been providing menopause education for the last 20 years. And so therefore, there is so much misinformation now. So fast forward 12 years ago to today, as I mentioned, no one talked about menopause or menopause hormone therapy, and it's only really begun to be common knowledge, and the stigma behind it has begun to decrease. However, there's now become this whole notion that everyone needs to be on hormone therapy or that it should be used for X, Y, Z. And I really want to today break all of this misinformation for you. Everything I share with you is based on Canadian menopause guidelines and international menopause guidelines, because there is, like I said, there's a lot of misinformation. I want to correct this misinformation for you, and I want to equip you with the knowledge so that when you go back to your family doctor, your primary care provider, or you are seeking out other providers to give you this information, I want you to be aware of what is true and what is not true. So first of all, why should I use MHT? And why do I call it MHT? Because it's not HRT. HRT is hormone replacement therapy. So that in and of itself we need to correct. HRT is for women who are under 45 who have gone into menopause before the natural age of menopause. The natural age of menopause is 51 on average, but it can range from 45 to 55. If you've gone into menopause spontaneously or surgically under the age of 45 or from chemotherapy or radiation, this is considered an endocrine deficiency, just like hypothyroidism, for which we are replacing the thyroid for hypothyroidism, or we are replacing the estrogen in premature or early menopause. That is when we use the word HRT, and we use higher than average doses of hormone therapy. MHT is for the average woman, perimenopausal or menopausal, who are using average dosages of hormone therapy to treat symptoms. And so if you want to use the correct terminology, if you're an average age woman, it's MHT. Why are we experiencing this? Because menopause is a full body change. We have estrogen receptors through our entire body, from head to toe. There are a lot of estrogen receptors in our brain and many different pathways in the brain. That's why your hot flashes, they are not just in your head, they are actually occurring in the brain. And there is a mechanism of action that we actually now understand, and we have targeted therapies that don't use estrogen to treat your hot flashes. Sleep disruption is a huge concern for many patients in perimenopause. This is again due to hormone changes, depression, anxiety, irritability, that brain fog that you all hear about and talk about. What is it about the brain fog? We have evidence that there is effects on verbal memory recall, meaning you cannot remember something, you cannot remember why you went into a room, you're forgetting things, or it could be just concentration difficulties. But when we actually put women with brain fog and we compare their executive function to men of the same age, guess what? We still do better, okay? So therefore, don't be afraid of your brain fog. And we have very good data to actually suggest that these symptoms that you're experiencing in the perimenopause actually improves postmenopause. And Dr. Cindy Barha did a talk yesterday about brain changes in the perimenopause and menopause. And so I really want to assure you that if you have brain fog, you are not going to develop dementia. This is a normal part of the perimenopause transition, but it doesn't lead to long-term consequences for the majority of women. There is also the genitourinary syndrome of menopause. Put your hands up if you've heard that term before. Okay, good. I see lots of hands. This used to be called atrophic vaginitis or vaginal atrophy. Atrophy or atrophic is a very negative term. So we've now called it since 2014 genitourinary syndrome of menopause. These are the vaginal changes, the urinary changes, and the effects on sexual function that occur because of a drop in estrogen. And if you think about the way that these structures are actually formed, during gestation, they all come from the same embryologic structures, which is why we want to put them all together. Many women report skin, hair, mucosal changes, which can affect our self-esteem, our self-confidence, the cardiometabolic changes, the weight gain, the visceral fat, so the fat that's not underneath your skin but around your organs. We see women who develop high cholesterol or blood pressure changes or diabetes that we really don't understand why when we haven't changed our diet or exercise. And then we also talk about the musculoskeletal syndrome of menopause, where women are beginning to experience joint pains or frozen shoulder or other symptoms that might not necessarily be evaluated or picked up on any imaging. Why is this all occurring? So again, because we have estrogen receptors in our bones and in our joints as well. There is no one menopause syndrome. So if there's 230 of you in this audience, all of us born with ovaries, and those of you who are not, who have people that you love that are born, none of us will have the same menopause transition. Therefore, if you are going to a provider who gives the same thing to everybody in that clinic or in that program, there is a red flag there, because there are so many different forms of hormone therapy, and we need to individualize your therapy to your symptoms. If you look at this list of symptoms here, does this work? Oh, no, it doesn't. Is there a pointer?
Green button.
Is there a pointer though? No? No. Okay. 4 different women, 4 different types of presentations. Hormone therapy, it may not fix every one of these symptoms. So we need to think outside the box. Where does hormone therapy actually work, and where may there be a reason to consider other therapies on top or in replacement of. Vasomotor symptoms, those hot flushes and night sweats. 80% of women experience hot flushes at some point in the menopause transition. This is not something that just comes and goes, that you just have to push through. This actually lasts for a very long time. We have to also be aware of ethnic differences. African American women and Hispanic women experience worsening vasomotor symptoms, both in terms of severity and frequency. My patient Shirley in that photograph is an Air Canada flight attendant, and she was having hot flushes every 40 minutes. She was serving her clients, and she'd have to go back into the bathroom to dab and dry herself, and in those uniforms. This was severely impacting her day-to-day function, and because she was a woman who could not use estrogen, she was desperate for help when she came to see me. The other thing you have to also be aware of is that just because you're in that perimenopause or menopause and you think, okay, at 60 it should be done, 40% of women are still experiencing hot flashes in their 60s, and 10 to 15% over the age of 70 still have hot flashes. Therefore, your quality of life matters. And if you are suffering, please seek out help, because these hot flashes can be very, very bothersome. The other thing I would also say is that for women who experience hot flashes for a prolonged period of time, it might actually be a biomarker of heart disease. So there was a study that looked at the carotid intima media thickness, so the carotid arteries, looking to see how much plaque was in the arteries. And for those women who had the most severe symptoms, they actually had more plaque in their carotid arteries compared to women who did not have hot flashes. So we need to keep in mind that it could also be a biomarker of heart disease if it's prolonged for a longer period of time. So why should I use menopause hormone therapy? Here are the guidelines for the alleviation of moderate to severe hot flushes and night sweats. We don't see the word brain fog here. We don't see the word palpitations here. We don't see the word prevention of aging or heart disease. It is for the alleviation of hot flashes. For the ideal patient, for a woman who's younger than age 60 or within 10 years of her final period and without any contraindications. So why should you as a woman consider menopausal hormone therapy? What do we have strong indication for? As I mentioned, bothersome hot flushes and night sweats. In the USA, there is also the label for the prevention of osteoporosis. We don't have that here in Canada. And I mentioned the word premature menopause and early menopause. So for women who've gone into menopause under 40, it's called premature menopause, POI, premature ovarian insufficiency, or early menopause. That's about 5% of women, 40 to 45. And I'll share with you that I am 43 and I'm actually menopausal. So my mom went into menopause at 43 and I've had hot flushes up to 12 times per day. So I know exactly how this feels. And I have an indication for hormone therapy. Genitourinary syndrome of menopause, we also have a strong indication. In the middle column, may or may not have indications. So why I say may or may not, if you're having hot flashes that are causing some of these symptoms, we know that it can affect your sleep. You wake up with brain fog, you're more irritable, your mood might be more disturbed, then these symptoms will improve. But if you have isolated symptoms, maybe just joint pains, or maybe just palpitations, we don't have a strong indication that menopausal hormone therapy will work. Now keep in mind, everything is nuanced, and some patients who come in desperation, I will do a trial of menopause hormone therapy to see if their symptoms resolve. But if it doesn't, please know that there is other things that might be causing your symptoms, and we can't always say that hormone therapy is the way to go. We also need to consider sleep, because oftentimes we classify sleep as a symptom of menopause, but we have to also recognize that chronic insomnia or obstructive sleep apnea that's not being treated is also affecting your sleep, and no amount of hormone therapy is going to correct that. So we have to diagnose and treat the sleep apnea. We have to diagnose and treat the chronic insomnia as well as an adjunct, or potentially rather than hormone therapy. Hormone therapy is not indicated for hair loss, heart disease prevention, dementia prevention. It is not for anti-aging. Therefore, please don't feel like you've got that FOMO of fear of missing out if you can't use hormones, because there's many other things that we can do to optimize your health. It is actually weight neutral. So hormone therapy is not going to directly increase your weight, nor is it going to directly make you lose weight. There is some data that it has evidence for body composition changes, so back from that, android shape to the more gynoid shape, but in reality, I haven't seen it, nor is it supported in the evidence specifically for weight management. I do know that women who feel better on their hormone therapy may make better lifestyle choices and therefore have weight changes. It's also not indicated specifically for low libido. What about hormone testing? That's a big question. And so I share this slide with my patients sometimes because I want you to see that in that perimenopause, estrogen levels are fluctuating significantly from very, very high to very, very low. And that means that if anyone is trying to get you to do a blood test in the perimenopause to see where your hormones are at or if you're balanced, that is something to run away from. That is a red flag because your estradiol levels change from hour to hour and from day to day. So using an estradiol level to determine the stage of your menopause transition is not valuable. I know there are patients who may get charged a lot of money for very expensive hormone tests. This is not supported in any guideline internationally. And even when you're in menopause and wondering, like, where am I at? For the average woman, average patient, you can see that estradiol, which is the most potent form of estrogen that comes from our ovaries, are very low. So you're not going to have changes in those levels regardless of when you do them. There is only a caveat for when we do an estradiol level. And the only caveat is if you have a patient who is on an appropriate dose of hormone therapy that you know for the majority of patients her symptoms respond to, and she's still having a lot of hot flashes, there may be some questions around whether or not there's appropriate absorption, especially if it's a transdermal gel or patch. So in those small cases, there may be an indication, but for the average person, you start your hormones, your hot flashes are gone, there is no need to do any hormone testing. We've talked a little bit about this. So when is hormone level testing indicated? The only evidence in the literature is for women who are under 45 and who have gone more than 4 months without a period, because we need to assess, is she in early menopause or premature menopause? Is she pregnant? Does she have a prolactin secreting tumor? Does she have thyroid dysfunction? So we do an FSH, a follicular stimulating hormone, which is coming from the brain that sends a message to the ovary to ovulate every month. And if that ovary is not working, you're not ovulating, that FSH level drives up because it's getting angry. It wants to send a message, a stronger message to the ovary, and therefore that level will be elevated. Anywhere above 30 is what we're looking for. My FSH was 110. So that is the blood test that is indicated for only diagnosing earlier premature menopause. Urinary testing, the Dutch test, salivary gland testing, very expensive test, not supported in any guidelines across the world. Who can use hormone therapy? Here are the contraindications on the left. If you have a history of active or past history of breast cancer, including triple-negative breast cancers currently in the guidelines, a history of a pulmonary embolism or deep vein thrombosis, so a clot in your lung or in the lower legs, in the deep veins of your lower legs. We do have some evidence now. So these are guidelines. Remember, everything comes with a little bit of gray. There is some literature that people who have had a provoked blood clot, there may be some role for transdermal estrogen, and you would need to see a specialized menopause provider to be able to guide you with respect to your specific circumstance. If you've had a stroke or a heart attack, we don't recommend systemic hormone therapy. Active liver disease, so like a hepatitis, if you have fatty liver, this is not a contraindication. And for women who are above the age of 60 or more than 10 years from her final period, to initiate hormone therapy is a bit risky because we have a window of opportunity for which hormone therapy is beneficial and safe. But for these patients in general, we don't recommend it. Remember, your biology is more important than your chronology, so it does require a nuanced approach. But in general, we're a bit more wary once you hit that age for initiation. And any undiagnosed bleeding does require a workup before we start. If you have any of these comorbidities in the center, diabetic, smoking, high blood pressure, obesity, even if you have an increased risk of breast cancer or a mother or a sister who's had breast cancer, it is not an automatic contraindication. It is nuanced. For some of these comorbidities, we would recommend a transdermal estrogen, meaning the gel or the patch, because it bypasses the liver, so it does not increase clot risk. For patients who are worried about their breast health, we have a couple of hormone therapies on the market that are very not well known. One is called Duaviv or T-Sec, and the other one is called Tibella. That does not stimulate the breast, and it does not increase breast tissue density. If you have migraines, you also can use systemic hormones, but we prefer transdermal estrogen. And if you are on the right-hand side, then you are pretty much clear for any of the therapies that we have available in the market. I want to just show this to you because a lot of women are worried, if I take hormone therapy, am I going to have a heart attack? Because we know from the Women's Health Initiative, this is the big, large study that was done, back in 2002, which basically stopped us healthcare providers talking about menopause and hormones. And I wanted to show you this. This looks like a complicated graph, but really what I want to demonstrate is what is the actual absolute risk of developing a heart attack, which is CHD, coronary heart disease. That's the blue color, in both the left and the right. So on the left-hand side, so this was a large study, thousands and thousands of women who were put on hormone therapy for prevention. So we wanted to see, does it prevent heart disease or other chronic medical conditions? On the left-hand side were women who had a uterus. So they were taking both an oral estrogen and a progestin. And on the right-hand side, women who did not have a uterus, so hysterectomy. We then divided up based on age. So 50-year-old women, 60-year-old women, and 70-year-old women. And this is important to know because when the information was leaked to the media back in 2002, they clumped all of these women into one single statistic. But if you look at this, on the left-hand side, a 50 to 59-year-old woman with a uterus who took oral estrogen and progestin, 5 out of 10,000 women had a heart attack. And you can see on the right-hand side, actually, there was a decrease. So less than like 10 fewer women. If you look at breast cancer on the left-hand side, only 5 additional breast cancers per 10,000 women. And on the right-hand side, there were fewer breast cancers for women who were taking estrogen alone with a hysterectomy. And as you can see from the ages, as we go up between 60 and 70, the risk increases. So what I'm saying is that there is a window of opportunity for which hormone therapy is very safe, and that is for those women under the age of 60 for initiation. And this is just to give you a little bit more information about the Women's Health Initiative. The average age was 63. The average age for menopause is 51. So these women were much older. Some of these women were smokers. Some of these women had already had a heart attack. Some of these women already had diabetes. They were asymptomatic and they were using oral estrogen, which means that this is not the type of data that we can actually use and extrapolate for ourselves when we now have transdermal estrogens. Women are a lot younger starting their hormone therapy, and we're using it for symptom relief. So I think I've already mentioned that. So the window of opportunity is for women under the age of 60 or less than 10 years from her final period. Cardiac risk. I just want to take 2 seconds to talk about this. If you can remember one thing on the slide, SMRFs and SMRF-less. SMRFs, standard modifiable risk factors. So when your doctor is doing a Framingham risk score, they're looking at your cholesterol and saying, you should take a statin, or no, you shouldn't take a statin. The only things that they're looking at, because this is it's a challenge within our current medical practice, is that the algorithm that we're using to identify your risk of heart disease is based on very standard risk factors: high blood pressure, diabetes, high cholesterol, smoking, and obesity. But they do not take into account women's sex-specific risk factors. So if you had gestational diabetes, preeclampsia, preterm delivery, PCOS, or premature menopause, we don't have a calculation to put into our algorithm to indicate that this increases your risk, even though we know that this is sex-specific risk factors for your heart health. The other thing is that there's more than that. There's what we call another SMRF-less risk factor is that even when we go through a standard treadmill test or a echocardiogram or even an angiography, many of us who may be at high risk for heart disease don't have any obstruction in our coronary arteries. And that's what INOCA stands for, ischemia in non-obstructive coronary arteries. So we are missing the boat for so many patients in terms of really understanding what is our actual heart health risk. So I just want to keep that in mind as you're thinking about hormone therapy and your heart health. I have 2 minutes and 35 seconds. I don't know how I'm going to do this. So I'm going to keep talking until someone tells me to stop. Okay, breast cancer. A lot of women worry about breast cancer. So this is what is a really nice diagram that helps you understand relative risk for breast cancer and what are the risk factors. At the very top, that BRCA1 mutation or 2 mutation, highest risk for breast cancer. What is your second highest risk? Dense breasts. How many of you have had a mammogram and have been told or have read your mammogram and actually know what your breast density is? Please show your hands. Okay, so maybe half of you. This is so important to know because your breast density is the second highest risk for breast cancer, not hormone therapy, not your mom's history of breast cancer. You can see a relative risk of 3.3 compared to 6 for breast density. And if you go all the way down, the second lowest risk is hormone therapy for more than 5 years. So what I'm saying is hormone therapy does increase breast cancer risk by about 1 to 2 additional cases per 1,000 women after 5 years of use, but it's still pretty relatively low. And if you compare that to obesity or alcohol use, drinking 2 units of alcohol per day has the same risk of breast cancer as being on hormone therapy. So I just want you to keep in mind that hormone therapy does increase breast cancer risk. It is a small risk. You should be aware of it, but your breast density is more important and actually increases your risk more than even just the hormone therapy itself. What kind of hormone therapy should I use? I just wanted to put this out there because I really want to help patients understand what are all these different hormone therapies. So a natural hormone is that conjugated equine estrogen, or Premarin, maybe many of you have heard of, and it's called Premarin because it's basically conjugated estrogens that is coming from a pregnant mare or pregnant horse. It comes in an oral tablet or in a vaginal cream. Now, what about bioidentical? This is like the sexy term that everyone gets thrown around. You should be on bioidentical hormones. Let me just clarify what that means. We actually produce 4 forms of bioidentical hormones in our body: E1, E2, E3, E4. Estradiol is the most potent one, and that's the one coming from our ovaries. And then there's progesterone. So when you are going to your doctor or provider, and you're asking for bioidentical hormones, all that means is that this product, it's still made in a lab, oftentimes it's plant-based, but it is in molecular structure the same as what your body produces. So it can come in 2 forms: a compounded form made by a compounding pharmacy, or it comes in a pharmaceutical grade Health Canada approved hormone. And so when you think about estrogel or estradot or Divigel or your estradiol oral tablet or Estrace, these are all bioidentical, but guess what? They're pharmaceutical grade. They are not compounded. What is the concern with compounded? I'll tell you in a second. If you look at the right-hand side, synthetic hormones, ethinyl estradiol is the main form of estrogen found in all the birth control pills we've all ever taken. And none of us blink an eye when we take that. And then there's many different types of progestins, which are listed here. The Mirena IUD, that's a levonorgestrel progestin. Again, these are synthetic hormones, which we use very comfortably for birth control and contraception, and we don't blink an eye. But then when it comes to hormone therapy, we're so worried that we must be in a bioidentical. The bottom line is whether or not it's bioidentical or synthetic, if it's a pharmaceutical grade Health Canada approved product, it has gone through large randomized control trials, and we can tell you safely what its benefits are and what its risks are. When you think about a compounded hormone like Bias, where they're combining things in a compounded fashion that's custom made for you, this is not regulated, meaning we have no control over how much of the active ingredient is in that cream that you're putting onto your skin. And from patch to batch or pharmacy to pharmacy, we have no verification about its safety. We can't counsel you about risks or benefits. And therefore, when you're asking for a bioidentical hormone, what you should be asking, more importantly, is can I have a hormone therapy that is approved by Health Canada? Because those are hormones that are covered by your insurance company. You don't need to go see an expensive hormone doctor to prescribe it to you. And you don't need to have any expensive hormone testing done either. If you use a pharmaceutical grade hormone, you can be comfortably aware that everything that we're prescribing to you has been approved by Health Canada. And the Canadian Menopause Society has menopause hormone therapy tables that demonstrate what those appropriate dosages are. And this is all free, available on our website. What kind of hormone therapy should I use? So here's the MHT tables. And many of you, if you have heard of Estradot or are on Estradot, and you're seeing shortages across the country, we actually produce an equivalency table, meaning if your doctor is not sure how to convert from one to another, we have a table that we developed last year that helps your family doctor, your provider, switch you from another product, which is about similar in terms of its dosage and strength. I also want to talk to the women in this room who cannot use hormones. And this is an area that really is close to my heart because I see a lot of breast cancer patients, a lot of breast cancer survivors who feel that their symptoms of menopause are not well supported because they can't use hormones. And so I just want to kind of give you a quick preamble about what we have as good evidence and not good evidence. Natural health supplements, as you can see on the right-hand side, we don't have any good evidence in the literature to use those for hot flashes. Cooling techniques, avoiding triggers, paced respiration, the literature does not support it being very effective for hot flashes. Weight loss, especially in the early menopause, can help reduce hot flash frequency. Cognitive behavior therapy and hypnosis have level 1 evidence to treat your hot flashes. And if you are interested, want to come chat with me after, I'm happy to give you some resources on where to find that. And then we have some medications as well that are prescription, but non-hormonal. And this one on the bottom, the NK receptor blockers, target the area in the brain. There's a group of neurons called KNDy neurons, KNDy, that actually, this medication targets the KNDy neurons in your brain that control your body's thermostat. In absence of estrogen, these KNDy neurons become very dysregulated and you start having hot flashes. So we give a woman estrogen back, the hot flashes go away. But if you can't use estrogen, there's another back door, and it's through a peptide or a molecule called neurokinin. And if you block neurokinin from binding to its receptor on the KNDy neuron, 70% of your hot flashes are gone. So it's very, very, it's been a huge game changer for all of us providing menopause care for patients. So again, just across the world, there's no evidence for supplements. The Canadian Menopause Society, we also have tables and dosages for what you can use that are non-hormonal, and we have an SOGC guideline from 2021, and actually on Tuesday, we have our first guideline meeting with the SOGC combined with the Canadian Menopause Society for updated 2026 Canadian Menopause Guidelines, so it's coming. When can I start and stop? I'm going to talk for 2 more minutes, and then we can take questions. Perimenopause. So you don't need to wait until you're in menopause to start hormone therapy. In the perimenopause, meaning you're having some changes in your periods, maybe every 7-day differences, maybe you're skipping months, you can start menopause hormone therapy. But I want you to keep in mind that traditional menopause hormone therapy is a very low dose of hormone, and oftentimes it is not enough to treat your symptoms. And on top of that, because you're still having some ongoing ovarian function, you're going to have more bleeding issues with traditional hormone therapy. So the secret to treatment in the peri is to suppress and substitute, meaning suppress ovulation by using a contraceptive pill and then substitute with add-back hormone therapy. So I've given you a list of a few things. If you can't use estrogen, you can use a progesterone-only pill. You can use estrogen with a progesterone-only pill. You can use a contraceptive. So I know a lot of patients are like, I don't want to take a birth control pill. But we actually have what's called the CDC medical eligibility criteria that says if you're healthy and perimenopausal, you can actually still use contraceptives until the age of 55. So, if you have appropriate counseling, it is not incorrect to do that. In the late perimenopause, again, you can continue on with your contraceptive, or you can switch to traditional menopause hormone therapy, or you can use what I talk about as Duaviv, which is that which is a menopause hormone therapy that is a little bit unique because it combines estrogen with a different type of a molecule, and it does not increase breast density. We've talked about the timing of menopause. If you are a woman who is in premature or early menopause, you are using HRT. Now we all know what that means. And you're using HRT if you don't have any contraindications until the age of 51 at minimum, because we want to prevent the long-term consequences of not having estrogen in your body. When should I start? When should I stop? So I think I already talked about all of this. When should I stop? So, my doctor says I've been on hormone therapy for 5 years, or now I'm 60 years old. Should I be stopping? I want you to remember that symptoms of hot flashes can last for 7.4 years, and there are women who are still having hot flashes in their 60s and 70s. I see someone having a hot flash over there. So I feel you, friend. So the answer is that you don't have to have a finite date to stop. The bottom line is that you need to have a risk-benefit conversation with your family doctor or your provider. This is shared decision-making. What are the benefits of me being on hormone therapy? What are the risks? And every year or two, you need to evaluate your whole health history to make an appropriate choice. Remember, we can change dosages, we can change regimens, we can change formulations to make it safer for you. And so how should I use it? Just want you to know there are some side effects. Initially, it takes up to 6 weeks before you notice an improvement. You can have some breast tenderness. That's very common. If you've had your mammogram done before you start, which I do for every patient, you don't need to worry. Headaches, breakthrough bleeding. Sometimes progesterone can cause bloating. And some irregular spotting for the first 6 months with starting, stopping, or changing a hormone therapy dose is considered normal. If you increase your dose of estrogen, you also should increase your progestogen dose as well. If you're using a gel, it says on the product monograph to put it on your arms. No, we don't put it on arms. We actually want to put it on our thigh. The reason why is we want to use a large surface area, because the larger the surface area, the better the absorption, and you're using the same thigh every day. With the patch, it's either your buttock, your thigh, your hip, or your abdomen, and you're changing it around every 3.5 days. Progesterone creams. We do not have any Health Canada approved progesterone cream. If you are using a progesterone cream, this is not regulated. Micronized progesterone is the oral tablet. It's a round pill. You can either take it orally or put it inside vaginally if you have any side effects that you want to, mitigate. And I think I'm coming to the end here. Again, these are tables that are available online. And I just want to point out a few little things here. So MQ6.ca, if your family doctor is a bit lost, doesn't know how to help you, MQ6 actually has a beautiful algorithm that is, you can basically put in your medical information. It's free of charge. It's made by one of my colleagues, Dr. Susan Goldstein, who is a board member of the Canadian Menopause Society, to help guide you as well as your family doctor about how to start hormone therapy. We also have a brand new, I was very fortunate to be involved in a primary care pathway with Alberta Health Services. There is a physician pathway as well as a patient pathway. It's got so much rich information, and that's the QR code to find it. And then Canadian Menopause Society, we have a lot of resources on our website, mq6.ca, the equivalency tables. And I also want to highlight the Menopause Foundation of Canada. We have created immense number of amazing tools. There is one tool as well as a resource called How to Assess Private For-Profit Clinics to be able to help you determine, is this a place that I want to, use, or are they, following guidelines, or are they doing things that might not necessarily be evidence-based? And I think that's the end of my slide deck. Almost, I think. I just wanted to highlight here that I do run a menopause practice here in Calgary, and we have a brand new center that's opening up next month. And the last thing I want to share is that when we educate and empower a woman, it is not only a personal asset that can never be taken away. We set in motion a powerful ripple effect that extends to all your families and communities. So I wish you good health and an empowered midlife. Thank you so much.
Well. That was about 6 hours of information. And information I think we were clearly starved for. Was that new information to anybody? Yeah, right? Yeah. So less than 4 minutes for questions.
Sorry.
Now. But that's okay, because I think the thing that's going to help us the most is some of these resources that you have, so that we can actually go through some of these questionnaires. We can bring this information to our physician, and then we can refer to them. If they're not comfortable, we can refer them to the physician pathways that you've described there. Is that through the Menopause Foundation?
Yeah, so I would say that the best place to start, really, now that we have this tool, is the Alberta Health Services primary care pathway. There's one specifically for patients, and we spent about 4 months going through this pathway. It's like 40 pages, but it will give you the core information that you need to understand your menopause journey. But then there's also a physician pathway. So then you and your physician can be on the same page, talking the same language, and having an understanding of how to support you. I think the big thing that I really wanted to get across today is that there is so much misinformation.
Yep.
And I really want to ensure that patients are equipped with the correct information. because this is your body and this is your health, and you deserve to have the right information. And, you know, as a board member of the Canadian Menopause Society, one of our missions is to educate primary care providers. And I can confidently say that today, your family physician is better equipped than they were a year, 2 or 3 years ago.
So it is constantly changing, and
say,
menopause is becoming a thing
we
that
are
people
getting
are paying
better.
attention to.
We are getting better, and we know that it's frustrating, but I want you to know it's a challenge, because we've been afraid of hormones for so long that we haven't had this education. This is not your doctor not trying to want to help you. They're afraid. They're genuinely afraid, because it does seem scary when you're worried about causing a breast cancer.
That's because we have menopause rage. That's why they're afraid. No.
I feel ya.
Okay, so we appreciate you so much. Talk about Milestone for a moment.
Can I talk about Milestone?
Please talk about Milestone, because it's not just you. You have got other doctors, because you are just one small gal, and you can't help everybody. But you've got other physicians that can do the same kind of work.
So why Milestone was created, first of all, I called it Milestone because I want women to see this as a positive chapter in their life. I know it feels like we're falling off a cliff. I get that. I know what it feels like when you lose your fertility, and I know what it feels like when you just don't feel like yourself. But you know what? I'll tell you, for me personally, after seeing so many patients, I think the golden year for women is 60. Because women at 60, they're empowered. They're no longer having periods. Their sex lives are better because they have more time with their partners. Their work demands have improved, and they own who they are as women. And so I call this a milestone. Menopause is a milestone. And why I've created Milestone? Because I cannot do the best for my patients with me just by myself. So Milestone was created because I wanted to make it multidisciplinary and comprehensive. So the first step is, when a patient is referred, you will be invited into the space for an educational evening. And then once that's completed, you will be invited to attend a 2-hour breast, bone, and heart health assessment. So you will be spending time with a registered nurse who's going to do education for you about your heart health risks specifically, and those sex-specific risk factors. We're going to talk about your bone health. We're going to talk about your individual risk for breast cancer. And these calculations come with algorithms that help me to then figure out what is the right hormone therapy.
But just in those 2 sessions, you have spent more time educating and listening than we're getting an entire year from our family doctor.
Initially when I've developed and created this model really just based on listening to you, all of you. And I know that education is the core. It's the key to your success. We have to do the education. I can't just write you a prescription if you don't understand why I've made that selection. So the education is so key. Then we have already 5 Menopause Society certified physicians, and this is the first center in all of Canada that has 5 physicians, Menopause Society certified physicians, working under one roof.
It is amazing. I've heard amazing things about it.
We have Dr. Lauren Walker, who is going to be providing psychology care, sexual health care. We've built a gym in the clinic. Therefore, I'm going to show you all how to build muscle. We have a trainer, because we need to learn how to strength train. We need to learn how to build muscle.
Oh, you weren't here earlier. We did.
Oh, you did? Oh, perfect.
We learned.
Excellent.
Yeah.
And what else do we have? We have pelvic floor physio. We have 3 incredible pelvic floor physios, which they're actually here today. Alana is one of them. We have a pelvic health physician as well. And you know what? The sky is the limit. Your needs, I listen to, and then we implement. That's the bottom line. Milestone is about implementing what women need, because I'm here for you. I'm doing this for all of you.
Well, we're here for you, and we keep you here all day, so you better get out of here.
Thank you.
And we'll move on. Thank you so much.
Thank you.
And honestly, absolutely. We were so starved for your information that you brought us today, so thank you very much.